Okay, let's talk about physiotherapy. My name is Václav, and now we'll focus more on physiotherapy and its assessment and potential benefits for cyclists. It all started with cycling for me. When I was younger, I used to race cross-country Olympic mountain bike races, and when I started studying at university physiotherapy, I slowly turned my focus to road cycling. At the time, I was also diagnosed with type 1 diabetes, and this combination, the diagnosis and me racing on road bikes, made me eligible to talk to Team Novo Nordisk and get to their talent ID camps, where I was selected to race for their development team for 2 years. Before I signed my contract with Team Novo Nordisk, I already finished my studies, and I was able to focus solely on my cycling career. That didn't turn out so great, so after 2 years in Team Novo Nordisk and 1 year at Dukla Praha, I decided to get back to finish my master's degree as well. Physiotherapy is a medical profession, a medical field of helping clients to a higher standard of life in general, meaning we are not healing patients as doctors through either surgeries or medications or other things. We are mainly working with the movement therapy as a pinch of salt sprinkled here and there, some manual techniques, at least in my case. What does physiotherapy and bike fitting have in common? They're both assessing a movement of a client or a patient and trying to get them move, let's say, better, but I don't really want to use here today these determinant terms as a better movement or worse movement or a good position or a bad position. It's just adapting the body or the circumstances for the individual. In my work as a physiotherapist, I'm not only working with cyclists, I actually work at a sports clinic that specializes in athletes from wide variety of sports, but also general population. Our advantage is that this general population is also kind of sporty. This is what brings them to us, and the work for me is easier because they are motivated and trying to get back to the sport they love. And this is crucial. This motivation to work on yourself is important for us because I can give you plenty of tips what to do, how to work on yourself, how to try to change or challenge the body in various positions. But if you don't want to do it, then my work here doesn't have any sense. Most common problems that I see is, of course, back pain, something that affects in life pretty much each and every one of us. So that is common. And if we talk specifically about cycling, it's of course back pain again, but then in combination with various hip, knee and foot problems mainly. The typical client that I'm taking care of is one of 3 categories. First category is very young athletes, let's say teenagers at the start of their athletic or professional careers. So because they're growing up very fast and so on. So this is the first category. The second category is actual professional athletes, and the third category is your, let's say, general population, mostly guys and girls, men and women, 30 to 50 years of age with, all kinds of either acute or overuse injuries. Okay, one interesting case where bike fitting and physiotherapy really came together was a female pro rider, up and coming and track rider, and she came to our clinic with back pain, with big back pain. It turned out she actually called me from a training camp in the winter that she has a lot of back pain, she can't ride, she was in Spain, couldn't train, couldn't do anything. And after she came back, we got her to do MRI, and we saw there's a huge disc herniation in her lower back. So first, I've seen her once or twice here. We started working on some stabilization and actually releasing the hips to be able to move without moving the lower back as well, or the trunk as well. So the movement just happens in the one joint. And at the same time, around the first or second therapy session, I've seen her for bike fit as well, which really gave the answer to why that happened. Because she's not exactly tall, quite the opposite, and especially how her legs are long versus her torso meant that her cranks were way too long at the time, and she wasn't able to stabilize the movement of the hips or the pedaling movement in her hips, but actually it went higher and she was stabilizing with her thorax and with her hands a bit more. She of course had crazy saddle issues. So the reason was way too long cranks. I think we've shortened the cranks by over a centimeter, and that made her to pedal, that enabled her to pedal without moving so much in her lower back, and we dealt with the problem that caused this condition. And within like 6 other physiotherapy sessions, she was able to get back on the bike, and in a few months she was back riding and winning track races. Okay, so my clients, my patients, I would say roughly 90% or probably even more come in with actual medical condition or an acute injury or a problem that we're treating. The rest, in the single digits of percents, are prevention. Prevention in physiotherapy is working out because we have many parameters showing us that being and staying physical active is the most important thing you can do. It might take you a couple hours a week to stay physical active, which is taking your time, or you have to devote the time to do that. But in return, it'll lengthen your life by quite a lot, because muscle strength is one of the most important factors in longevity. Also, having a high VO2 max is going to prevent, not necessarily completely, but significantly decrease all-cause mortality in comparison with someone who has lower VO2 max. So in general, we can say that staying active, being physically active, is extremely important for your well-being and your health. What is interesting, we can see that in recent studies on Parkinson's and Alzheimer's, the cognitive training, as in doing, how are they called? Word crosses and Sudokus and others, isn't necessarily the best approach. If you let these patients or these people lift weights, walking outside, being active, their condition is either going to increase or their illness isn't going to progress as fast. Okay, so that brings us for prevention in cyclists. What is cycling specific about, or what is specific for cycling, is flexed spine. You know, you're like pretty much hunched over. Doesn't matter if you're riding enduro bike or a TT bike, pretty much in all options in between, you're getting power out in a flexed spine position, which is not wrong. Spine is a very robust structure that can withstand many forces, but we want to make the body adapted to it slowly.
And that brings us to prevention for cyclists.
What I imagine under the term prevention for cyclists, I imagine some quality movements of the back and of the hips. Differentiating between these two, well, because your legs are the powerhouse and you have to stabilize them somehow in the core. And in the core, and prevention is also strength training, of course, because you need lower back, core, leg strength. Everything has to be strong to be able for you to move either faster or longer, or just for you not to overload certain tissues and on certain muscles. And in general, the position on the bike is not something a human body is really used to. It's not really natural for us to be pedaling in circles and be hunched over. And I'm not saying that being hunched over in a flexed spine position is something bad, but it's something that if you're starting with cycling is something that you have to get used to. You have to get your lower back used to. And yeah, that's where physiotherapy and some specific exercises can help, even when you're not dealing with pain at the moment.
In terms of prevention of injuries, I would also mention the importance of good sleep and good nutrition, because all the other recovery tools as percussive guns or those lymphatic pants, or ice baths, even ice baths, they can be used. They have certain specific places and times where it's good to use them, but in general they bring only a few percent of improvement in recovery. The most important thing for recovery is good and consistent sleep and good nutrition. Prevention of injuries in cyclists is not an easy task, especially because we can't really determine when an injury is going to happen. There can be a crash, there can be a long training camp with not enough food or whatever, and the guy is getting overtrained. So we can do some steps to try to eliminate it, but we won't ever be able to determine an injury when or what is going to happen. So, for example, the things that we can do is we can assess the big joints through orthopedical tests to see if there's any underlying issue, as in laxity or range of motion or strength, and then we can assess movement strategies through functional tests and take all this examination and put it in contrast to the bike fitting and the position the rider is in on the bike. And thanks to this, we can assess the potential danger. A good prevention of injuries is quality warm-up and quality cool-down. What we saw from like 3 weeks ago was Tadej Pogačar, I think it was UAE Tour, when he was warming up, working out with rubber bands around his knees and ankles. And for example, that's a type of thing you can do before your bike ride. It doesn't have to be long, it can be 5 to 10 minutes. Again, you're just warming up, and this warm-up isn't straining your body hard enough to drive any adaptation in your body. So it doesn't have to be longer than 10 minutes for sure. And we would want to see some a little bit resisted movements through whole ranges in the knees and in the hips, whole ranges of motion. And cooling down in cycling generally comes down to riding your bike for extra 20 minutes after the race, which is a great way to get the body slowed down a little bit, get all the processes that have been running at the red line just before finishing the race, to cool them down a little bit. And yeah, riding your bike easy for 20 minutes is enough in the first part, but I would maybe lengthen out the cool down into more parts. So immediately after the race, yeah, go for a cool down ride, 20 minutes, and then in the evening you can do a little bit of yoga, again 10-15 minutes, get the body in different positions, get the body side bending, get the spine side bending, something new for the body that hasn't really been happening or isn't really happening while you're riding the bike. So get a little bit of more variety in your movement. You don't have to be racing for this to be true. Cooling down is important also after your regular training, social ride, whatever. The last 20 minutes, make it easier, come down, come home a little bit cooled down. So yeah, so you're not getting off the bike at your max heart rate. And if you're not doing these things, not warming up, not cooling down, what is in the long term, what could happen? Well, that's really hard to say. I don't think it should lead to one result, that if you're not stretching, you will, I don't know, your knees will hurt or whatever. It can manifest as more things for sure. I would say the reason why you're stretching, doing yoga after the ride or cooling down, is just to get the body a little bit moving in a little bit different ways, especially the yoga. Getting the body in different positions, loading the joints from a little bit different angles, and just giving the body more variety. I think that's the most important thing. And that goes to bike fitting as well. If we flip the script, again, you have the worst bike fit possible, but you're only riding 1,000 K a year. It's probably not really going to do anything because you're not as exposed to this position. It's all about exposure, what the body can take, what the tissues can take, and then what are you doing about it, either to decrease the load or actually trying to increase the load to increase your fitness. So when to come and see a physio? I think it's mostly when you have pain, when you're injured, and you've been through the, let's say, the more straightforward route. Let's say your knee hurts, so you go see an orthopedic doctor, orthopedic surgeon, and he tells you, well, there's nothing in there, but your knee still hurts. That's definitely a case to see a physiotherapist, because what the surgeon, orthopedic doctor usually means is there's nothing I can operate on, there's nothing I can do surgery on, but he might not evaluate the movement strategies, or if the quad is strong enough, or if the hamstrings are strong enough, or if the knee is being protected in some positions because the brain is afraid to load the knee more than this and this position. So yeah, those are the cases when you come see a physio. It doesn't have to only be orthopedic stuff. We are able to treat and help with neurological conditions as well. And yeah, after surgeries, I don't know, TMJ problems, temporomandibular joint problems, also with nausea and vomiting. If you have BPPV, that's also a thing we can very elegantly treat. So yeah, very wide range of stuff. Other examples could be muscle strains or tendon injuries and so on. At our clinic, we have 3 doctors, 2 orthopedic surgeons and 1 rehabilitation doctor, and around 6-7 physiotherapists, I think. And yeah, the physiotherapy session lasts for 1 hour. It's one-on-one, which is something that might not be common, let's say, in the US. And if necessary, we can always schedule appointment with the doctor. We have diagnostic ultrasound here, so because we specialize in athletic population, we are using this to assess the progression of, let's say, muscle strains or tendon injuries, how they look like, how are they progressing with time, and how are they reacting to the load they're receiving from the therapy and from working back home. So yeah, mainly the physiotherapist, let's say, will work with you, and at the beginning there can be an appointment with the doctor as well, but if any questions arise in the process, the doctor can be called or scheduled appointment with. And then of course we have just patients coming to see the doctor either, yeah, because there are some like orthopedical stuff meant to be treated by surgery, or to get some invasive treatment which we can't give as physiotherapists. The role of the doctor here is to make the diagnosis and help to clear any uncertainties that might arise. So when the patient comes, it can either be that he's just coming for the first time and he only has a physiotherapy, or he already has a doctor's appointment as well. So I'd say it's like 60-40 pretty much. 60% of patients, they will be like treated with the physiotherapists, and only would ask a doctor if anything's unclear, and the rest is already having an appointment with the doctor as well, just to set the diagnosis, and if it's something that is acute or recent injury, getting some maybe collagen applied next to the tendon or into the muscle or something to promote the healing right off the bat. In the first session, it might feel a little bit shorter because the initial assessment takes longer time, but we will set up the process. You will get, let's say, 2-3 exercises for you to work at home if your condition requires it, and we will treat any other stuff that needs to be treated, let's say. The general ideas we can work in, let's say, is that you can imagine that you came with pain, doesn't matter what or where, but you can imagine as a glass full of something, and when you have pain, it's overflowing. So you can deal with what's in the glass, and that can be factors that you either can or cannot influence. So you can't influence genetics, but you can influence maybe the stress load or some kind of other load management. And so we can work with what is in the glass, or we can just easily try to make the glass bigger, you know, getting the client stronger, so his body is able to like, let's say, like withstand more or help itself, because yeah, human body in general is very strong, and yeah, why not just use it? Or that's not a good saying, why not just use it? I would say let's also do from the specialized things. If it's indicated, let's also do some probably general strength, you know, never not enough of it. Okay, as physiotherapists, we probably won't be keeping you off of your sport. We might suggest a different sport for the time you're injured, and that is something that I wanted to talk about as well. If you're treating elite athletes and they get injured and they can do their sport, and then they can train for their sport or train the way they're used to, you really have to find some kind of training opportunity for them, being at a different sport or just doing weights in the gym for the body parts that are not injured. But this is extremely important, because you don't want the athlete to be losing fitness, losing performance. So you always want to find something they can do to prevent the decline in their fitness, even though they're at the moment dealing with injury. Of course, this non-specific training is also going to help the injury, not in the first couple of days, but later, as the pain settles down, this training will help to move the blood around the body a little bit more, and will actually non-specifically help the injured body part as well. So when you're treating an injury and you're actually looking forward to get back to your sport, you wanna have this route pretty much marked or you want to be led on this route mainly by a physiotherapist. So you will work at the beginning maybe on pain, swelling, whatever it might be. Then you're going to work on ranges of motion, strength, and other types of stuff. Then you're going to work a little bit more on the movement quality, and then some dynamic stuff as jumps or whatever is necessary for your sport. And then before getting back to the sport or before getting back to the training, there should definitely be some markers that you have to pass to show that you're ready to get back to your sport. Because if we won't do this final testing, or if we won't test throughout the process of return to play, the chance of getting a re-injury is too high. So there are some parameters that we can follow. We can do isokinetic testing of the muscles. We can follow limb symmetry indexes for lower limbs, upper limbs as well. We can do some stability testing, like a Y balance test, for example. We can do isokinetic testing and jumps, again looking for limb symmetry, and that is very important for us. So the work of a physiotherapist on this pretty much return to play starts with the rehab, with physiotherapy. But as the athlete, as the patient is getting better, the role of physiotherapy is getting smaller, and what is getting bigger is the role of strength and conditioning. If you're really talking about let's say a hockey player, you really need to keep them working out the other body parts that are not injured, and as soon as he's able to load the injured limb, you are trying to increase the load slowly. So you can also look at rehab as a part of a preconditioning part of the whole return to play process. So yeah, I think physiotherapy or rehabilitation and then strength and conditioning go hand in hand, and they're smoothly transitioning one into the other. So we will now go through some exercises to assess your mobility, a little bit of strength and stability, some functional tests that can help you either to identify some weak points or potentially weak points, or to use them just as a, let's say, like a stretching or a mobility routine.
What we're seeing here are different types of bending. Flexion, either through spine and hips combiner, or when you lean onto a wall and keep your pelvis stable, then you're able to isolate the bending forward flexion more into your spine. You can use this position to stretch your lower back muscles, or as an adaptation of the spine to bending, where you would even add weights. Assessment of some basic general movements like squat, single leg squat, and landing on single leg. These will give you an idea how body manages load across lower limbs and their respective joints. From these general movements, you have to dig deeper to assess, for example, ankle mobility, hip mobility, special hip tests like FADIR to screen for FAI, femoral acetabular impingement. Single leg RDL in B stance, pressing the knee into the box, stabilizes the knee in space and makes a coordinatively difficult movement like a hip hinge much easier, because you can focus solely on the hip and trunk movement coordination. RDL and hip hinging in general helps us assess the coordination between trunk and lower limbs and the variability the brain uses around your pelvis and lower back area. This is the first exercise specific to cycling. You're isolating hamstrings and glutes in a position that replicates trunk lean on a road bike, and with hovering the heel on the stance leg, you're driving the force nicely through the plantar flexors. Of course, hamstrings aren't the main muscle group utilized in cycling, almost quite the opposite, but that's the reason you might want to add single leg RDLs to your gym program. Wall Foldis exercise can be used to drive load through the knee and focus forces through the quadriceps. When the knee is injured, either acutely or chronically, pain can and probably will inhibit the activity of the quadriceps to protect the knee. This strategy might be helpful in the early stages. However, later we want to teach the body again to expose the knee to load. In this position, you can vary the load by 2 parameters. How high on the wall are you sitting, and how close is the heel of the stance leg to the wall. Lower position and heel closer to wall expose the knee to more load and patellofemoral pressure, so you can adjust the position based on your current pain. You want to exercise only up to pain intensity 2 to 3 out of 10, where 10 is your subjective maximum. Decline squat, almost a staple in knee rehab for cyclists. Harder variation of the previous exercise, where with the tilt block you're using biomechanics to expose the knee to load. There is protocol how to load the knee, published in a research article using this exercise, and you would want to get to 3 times 15 reps of single leg squats and then start adding external weight. This exercise engages your core. It is from a DNS concept, so coordinatively challenging. However, the total load is not high and it doesn't isolate any specific muscle group / function. What we're doing here is, in this position where your lateral abs are working harder, is that we are isolating hip movement. You're trying to step forward with your leg without moving anything else or losing the position. I like to think about this exercise as a hip mobility exercise. I also use this when rehabbing the track rider with disc herniation.